All right, let's continue on with lecture 17. We are still talking about some of our blood components that are derived from whole blood, but also we're going to talk about the cytophoresis process as well. Okay, so when we ended lecture 16, we were talking about platelets that were used from a whole blood unit. And I forgot to mention, remember that we said that usually whole blood platelets, it's not enough for a therapeutic dose, and that we have to pool 6 to 10 units together. When you pool 6 to 10 units, you are opening that system, changes the expiration date, okay? And because platelets are kept at room temperature, your expiration date changes to 4 hours, okay? All right. Remember, when you enter the unit of red cells, because it's kept at refrigeration temperature, that expiration is 24 hours, okay? Platelets, the #1 product that's going to have bacterial contamination, if you do the statistics, it's always platelets that are involved in when recipients become septic, okay? Because they're stored at room temperature, right? They're the #1 culprits that are involved in septic, right? So when you pull platelets, because you're accessing the mother bag and you're pulling all these donors together, your expiration date changes from 4 hours from pooling, all right? Right now, let's switch gears a little bit and talk about the apheresis collection. And you can use apheresis to collect the desired product. You can do red cells, you can do plasmapheresis, you can do platelet pheresis, you can even do granulocyte pheresis, all right? So we're gonna talk about platelet pheresis and granulocyte pheresis. And if any of you guys haven't ever done the apheresis process before, this is kind of what it would look like. You're gonna be hooked up to an instrument. It could use one arm or both arms, depending on what type of flow they're utilizing. But the instrument is going to pull off your blood, and it's going to go into your system. Right here, you can't really see it, but the system has a centrifuge, and it's going to centrifuge. It's going to keep the product that is desired. All right. So in this instance, we're going to talk about platelets first. So it's going to keep platelets, give red cells and plasma back to you. All right. This is what they will pay you for if you want to do the apheresis. There are some facilities that will pay for this. All right, so if you donate platelets using the apheresis, this is termed single donor platelets because we're using the apheresis technique, we can get a therapeutic dose of platelets from one single donor, okay? And typically we're going to pull off about 300 mils of platelets. The minimum number of platelets must be 3 × 10⁻11 per unit, okay? And if you think about it, if you were to pull 6 to 10 platelet units from a whole blood unit, this is a very comparable platelet count, okay? And just like our platelets from whole blood collection, stored at room temperature, 20 to 24 with agitation, okay? And the same dating period, 5 days from collection because it's kept at room temperature, okay? Has the same indications of use as our platelets from whole blood, right? Same thing. The good thing about apheresis is it only exposes the recipient to one donor, okay? Rather than platelets from whole blood being pooled, exposing the recipient to potentially 6 to 10 donors, okay? This is a single donor. We talked some in the previous lecture too when we were talking about leukoreduction and irradiation, about graft versus host, and we talked about HLA matching. If you have a patient that receives a platelet transfusion and their platelet count is not affected, #1, it could be due to a platelet consumption disorder. You definitely want to investigate that. #2, it might indicate that they are refractory, meaning that those platelets are not doing the patient any good. Their platelet count did not go up after that transfusion. And there is a known cause of that. Remember, we talked about how the white cells have HLA antigens on them as well. Platelets have HLA antigens on them too. So we saw this a lot here at UAMS. If your patient has a HLA antibody, that antibody could attack the platelets and keep those platelets from benefiting your recipient, all right? If that's the case, you have to give what we call HLA matched platelets. And we did that here at UAMS. So we had several patients that have to have HLA matched platelets, especially if they receive, those patients that are on chemotherapy and they're receiving multiple platelet transfusions, they more than likely might develop either a platelet specific antibody or an HLA antibody, right? That will cause them to become refractory, okay? All right, so you can also do the same thing for granulocytes. You can collect granulocytes through the apheresis technique from a single donor. Now, that granulocyte unit is actually going to contain some platelets and red cells as well. So you're going to have about 20 to 50 mils of red cells. And I want to show you guys what a unit of granulocytes look like, because when I think of granulocytes, I think of bushy coat. I think it's going to look like platelets. However, because of the contents of red cells, if you think about spinning a vacutainer tube down, how little that buffy coat is, it's very hard to obtain granulocytes without some red cells, right? And that's why. So this is what your granulocyte unit will look like. It does have some remaining red cells in there. Okay? And so your red cells, if this unit had been sitting for quite a bit of time, notice that your red cells are at the bottom, and then here's your white cells. Okay? So it does have some red cells. With that being said, because the granulocytes do contain some red cells, these granulocytes must be cross-matched, following the same cross-match procedure as you would if you were transfusing a unit of red cells. Okay, we want to make sure your patient's allo antibody in the plasma is not going to attack the granulocytes as well, because there are some red cells in there. And with that too, if your patient has a unexpected allo antibody, and remember we have to antigen type our red cells to make sure they're antigen negative, you also have to do that if your patient's going to receive a granulocyte unit, okay? So if you guys remember from the previous lecture, I also remembered we talked about the leukocyte depletion process. Obviously, we don't want to leukoreduce these units because we want the leukocytes. And then also, remember I mentioned at the patient's bedside, all units will also be filtered. You don't want to use a filter there either, all right? However, we would definitely irradiate, okay? So the radiation will not affect the function of those white cells. It will just prevent those T cells from proliferating, all right? So we still definitely want to irradiate. With the use of antibiotics, granulocytes, you will not see granulocytes very often. My experience in blood bank here at UAMS, I had 2 granulocytes in 5 years. All right, so you won't see granulocytes very often. But if a granulocyte is ordered, it will probably due to a patient that is severely septic and is not responding to antibiotics. All right, so we can give them some granulocytes to help fight off that infection. Usually your patients are going to have a very low neutrophil count, less than 500 per microliter. Sometimes they might even do it in neonates for babies. There's a transfusion reaction that we're going to talk about. It's called a trolley. So it's a transfusion related acute lung injury. So, and it's really has to do when white cells are transfused. And so the risk is increased when granulocytes are transfused. So that's a limitation of transfusing granulocytes. And then again, because you don't get very many white cells, the dose might not be considered therapeutic from one granulocyte apheresis. All right, expiration time, did we talk about that? All right, so we talked about storage temperature being at room temperature. Look at your dating period. Granulocytes are only good for 24 hours. So granulocytes are not an easy product to come by. It requires a lot of preparation. If a physician wants to transfuse granulocytes, they have to put in the order. The donor center has to be notified. The receiving blood bank has to be notified. The patient has to be ready to receive that transfusion once the hospital receives it. Okay? We don't want to waste that granulocyte unit. We want to make sure everything is ready for that unit to be transfused within the 24-hour expiration time. Okay.
When you get apheresis today, switch out the tubing between donors.
Yeah. So it'll be like a whole sterile kit, and it comes in a plastic bag. And for each donor, they open that plastic bag, and so they change it out. So everything will be like kind of connected.
And in the machine too.
Yeah. Yeah, so the machine, you know, will stay, but everything that is potentially touched by a donor is switched out. And then that system is remain closed the entire time. There was something else I was going to say about granulocytes. Maybe it will come to me in a minute. Yes, ma'am.
Like if they tag it or label it with something fluorescent, and then they can see how far inflammation goes, like in your organs. Do they use it for that?
I have never heard of that being used for blood products. I haven't. Not to say they're not. I have just never heard of it. Okay, so now we're moving on from our whole blood unit. We're going to go back to our whole blood units, all right? We can collect fresh frozen plasma. And it's called fresh frozen plasma because it is processed and frozen within 8 hours of collection. Now, I'm not sure what your lecture manual says, but if it says 6 hours, change it to 8 hours, okay? That's the key word there in fresh frozen plasma. It's fresh because it is frozen within 8 hours of collection, okay? And because it's fresh, remember factors 5 and 8 are labile factors, meaning that they break down pretty easily, quickly. Because this is fresh frozen plasma will contain all of your coagulation factors, including 5 and 8, okay? So that's fresh frozen plasma. There's actually another classification of plasma, and it is frozen within 24 hours after phlebotomy. Okay, so you might see it as PF24 or FP24. Could be written either way. That means that it was not frozen until 24 hours post phlebotomy. Factors 5 and 8 are going to be very diminished in that, okay, because they are very labile. They will break down quickly before that plasma is frozen. Does that make sense to everybody? That's the difference between fresh frozen plasma and PF24. So usually 1 unit of FFP is going to be about half of your whole blood, usually about 220 to 250 mils, okay? All right, so your storage temperatures. It's frozen, so in blood bank, think about your routine frozen temperature, -18. Fresh frozen plasma can be stored at -18 for up to 1 year, kept frozen for up to 1 year. If it is frozen at -65, it can be frozen for up to 7 years, okay? Now, obviously, we can't transfuse a frozen unit, right? So we do have to thaw it. The process of thawing, you're going to take your units of FFP. Usually, you're going to put it in some type of barrier like a Ziploc bag. something that you can close up. You're going to put it in a water bath that is at 30 to 35 degrees Celsius, and usually it's going to take about 20 to 30 minutes. Now, there are some water baths that have built-in agitators, so you put it in there, the little clasp holds it, and then it'll agitate it. That has sped up the thawing process, so it might take maybe 15 minutes instead. All right, but you have to use an approved process of thawing. Don't put it in a microwave, okay? And if you send out, we always have a running joke, if you send out a unit of red cells or plasma to be transfused, don't let your nurses try to warm it up by putting it in a microwave either, okay? Now, however, there are some FDA-approved microwaves that you can use for warming. It has to be an FDA-approved microwave, not your normal food microwave, okay? But most oftentimes you're going to have a water bath. I say that that'll make more sense to you why somebody would want to put it in a microwave. If you have a very strong cold reacting antibody and a patient needs transfusing, we will recommend the use of a blood warmer prior, during the transfusion. So some nurses might interpret that the wrong way, meaning that they need to warm the blood up by putting it in a microwave. All right. That story never happened to me personally, but it came from somewhere. Okay. So I always share that. It's funny, but it actually did happen, which is scary. Okay, so after the thawing process, your product attribute changes from fresh frozen plasma to thawed plasma. Once you thaw it, it is good for 24 hours, okay, stored at refrigerated temperature. Here's the thing. If you don't use it within that 24 hours, you can further change the attribute, and then it just becomes, plasma, okay? And then it's good for 5 days post-thaw date, all right? That is, I want to make that clear, that is not an approved FDA product, okay? So once you thaw plasma, FDA says it's only good for 24 hours. However, FDA, you guys will learn FDA and AABB kind of have some conflicting standards, all right? FDA does not approve that. However, AABB says it's okay. So.
Is it a different set of uses then?
So the only concern that you have is 5 and 8, all right? Because in fresh frozen plasma, 5 and 8 will still be there, but the longer that plasma sets out, the more 5 and 8 diminish. So if you were treating a factor 5 deficiency or a factor 8 deficiency, then you want to make sure you have the freshest plasma possible. Does that make sense to everybody? Sarah asks, so when it comes to inspections by AABB or FDA, how is that handled? I think AABB will accept it, and if you're inspected by FDA, you will not get, it will not get deemed as a deficiency, if that makes sense. So FDA, while they don't really accept it, they won't what's the right word? Yeah, they won't, your overall evaluation, your accreditation, it won't be revoked because of that. So, UAMS, we did that. We would extend our plasma date to 5 days. We did that. Cite, thank you. That's the word I was looking for. They won't cite you for that. There's, and we're going to talk about the factor concentrates at the end of this lecture. Plasma used to be the go-to for any factor deficiency, 7, 8, 9. However, now recombinant DNA we can manufacture those factor concentrates. Patients can give them to themselves at home. So the concentrates have really replaced the need for fresh frozen plasma. So, unless you have TTP, ITP, those types of things where they do a plasma exchange, and then we'll talk about that in just a minute, then fresh frozen plasma is needed. All right, so if you look at that chart that's in your textbook, this is where we are talking about the plasma products. A lot of students get confused by this, but I want to break it down for you, all right? The key word is in the product. Fresh frozen plasma, frozen at -18. That's our consistent freezer temperature, okay? -18 for 1 year if it remains frozen, okay? If it's stored at -65, it's good for 7 years, okay? Until thawing, of course. And then after thawing, it is stored at refrigerated temperature, and it's good for 24 hours, okay? And then AABB says you can extend that. It becomes plasma, and it's good for 5 days from the date of thawing. All right, so there's several different products there. Right, some uses of fresh frozen plasma, coagulation disorders, especially if your patient has liver disease. Remember, because pretty much all of our coagulation factors are produced in the liver, all right? Factor deficiencies. If your patient had a massive transfusion where they received multiple products, we always want to make sure they get plasma as well, and that's part of the massive transfusion protocol that we'll talk about. It's usually 4 units of red cells, 4 units of plasma, and 1 to 2 units of platelets. All right, that's your massive transfusion. It's called a mega pack. All right, so if you have a patient that's bleeding out, the physicians might initiate massive transfusion. That means they're getting ready to transfuse a lot of products into the patient. Replacement therapy for thrombocytopurpura. All right, you guys remember we talked about the Atom TS13 molecule and TTP. That's a ultra large von Willebrand's factor, and it causes the patient to spontaneous clot. All right, because it activates the von Willebrand's factor, which activates the clotting cascade. Right, remember that? You guys remember that from coagulation? So think about FFP. It is linked to coagulation. All right. So replacement therapy means that they will do a plasma exchange. So to remove that Atom TS molecule from the patient, they will take the patient's weight, they will calculate the average amount of plasma, they will pull that amount of plasma off and then replace it with fresh frozen plasma. They can usually pull that plasma together into one large unit, or they can transfuse multiple plasma units back to back. I've seen it done both ways. So you usually give about 4 to 6 units of fresh frozen plasma. A good rule of thumb is about 10 to 20 mils per kilogram. And because it is related to coagulation, we will monitor the patient's PT and PTT. And here's what your fresh frozen plasma will look like. It's not a concentrate, okay? So it doesn't have like one specific factor in it. It has all of the factors. So if your patient has hemophilia A, meaning that they have a factor 8 deficiency, maybe FFP is not the appropriate therapy for them. Factor 8 concentrate might be a better therapy for them, right? Okay. So it's not a concentrate, therefore it takes a larger volume to receive that therapeutic dose. Cross-matching is not necessary for FFP. We will give ABO compatible. However, we don't have to worry about RH. Why do we not have to worry about RH? It's not red cells. So your D is on your red cells, right? And so we're only concerned about ABO compatibility. Right? And so remember, your universal donor for red cells is group O, okay, because they don't have any antigens on their red cells. Your universal donor for plasma is AB because they don't have any antibodies in their plasma, okay? So I would go ahead and tell you that blood bank hoards their AB plasma. All right. We don't get it very often. And when we do have it, we tend to save it for AB patients. Okay, so if you guys remember from a previous lecture, we talked about another product that can be derived from FFP, and it's called cryoprecipitate or anti-hemophilic factor, AHF. So you might see it referred to as cryoprecipitate, AHF. All right. This can occur when your FFP is frozen and then thawed at 4 degrees. Okay, what's going to happen is you're going to have this very white precipitate form in that FFP. That precipitate is your cryo. All right. And you get it's only a very small amount, usually like 15 to 20 mils a unit. All right, so we have to pool cryo to achieve our therapeutic dose. All right, so what cryo contains? You guys need to know this. Cryo contains factor 1, factor 8, the clotting portion, and von Willebrand's factor, and factor 13. All right, so 1, 8, and 13, and von Willebrand's. So each unit of cryo must contain at least 150 milligrams of fibrinogen, and it must contain 80 international units of factor 8. That should be an 8 there, not a 7. I just noticed that. Cryo does not have factor 7. Just want to make that clear, okay? Storage temperature is just like our FFP. It's a frozen product, so it's stored at -18 degrees. You can keep it for 1 year from the date of collection as long as it stays frozen. Once it's thawed, because each unit has such a small amount and we will pull these together, once they're pulled, your expiration date is 4 hours from the time of pulling, okay? And then once you pull it, it is stored at room temperature. It does not go back in the refrigerator. Right. So some uses of cryo. Remember that for FFP, the longer it sets, factors 5 and 8 will decrease. So cryo is a more concentrated dosage for factor 8. Okay, so it's a better option than FFP. However, now we have factor 8 recombinant DNA concentrate that is a better option than cryo. Okay. It's used to treat von Willebrand's disease, deficiency of factor 13 and fibrinogen, those patients with liver failure, DIC, and we always worry about this in blood bank. If you have a patient in the OR, in the ER, wherever they are, and they have received a lot of products in a short amount of time, maybe massive transfusion protocol has been initiated, they've gone through 3 to 4 megapacks, you need to make sure that they are getting a dose of cryo, okay? And that's just to make sure that their coagulation system is still working after blood loss and then being transfused such a large amount of volume. Right, they will need to receive cryo as well because it is a more concentrated method of getting fibrinogen. Cryo is the only product that is a concentrate of factor 1 fibrinogen. Okay. The downside of cryo is that you do have to pull several units together to reach that therapeutic dose. So it does expose your recipient to multiple donors. So therefore, increased risk of infectious disease is the concern there. This calculation was in your textbook and I included it here. I don't want you guys to memorize this or anything, but I just wanted you to know the cryo dosage is based off of your patient's weight. All right, and that's really all I wanted you guys to know. right, so cryo is derived from plasma. What happens to that plasma after we pull the cryo off? We're still going to use it, all right? It's going to be called cryo-reduced plasma, or CRP, all right? You might see it referred as that. And again, it's going to contain all of your factors except fibrinogen, factor 8 clotting portion, von Willebrand's factors, and factor 13, okay? It contains all of those factors except what was pulled out with cryo. And so typically, once we pull cryo off, we'll refreeze that. So it's cryo-reduced plasma, and that refreezing must occur within 24 hours, and then it is still good for 1 year from the date of collection. Because this is occurring at the donor facility, all right? Not at your transfusing hospital. And then it's the same as regular plasma. Once it's thawed, you can refrigerate it, and it's good for 5 days. So if you had a patient that had TTP with that atom TS13 molecule, they might try to use cryo-reduced plasma because it lacks that von Willebrand's factor. And remember what these guys have, those ultra large von Willebrand's factors, all right, that Adams TS molecule, all right. All right, so just a few miscellaneous components that you may or may not have any exposure to being on the blood bank. When I first started working here at UAMS, we used to reconstitute factor 7 and factor 8. So we were actually involved in calculating the dosage for patients and then issuing that for injections. So you may or may not ever see that. All right, so factor 8 and 9 concentrate prepared from pools. This is prepared from donors at plasma centers, factors 8 and 9 concentrate. You probably won't ever see this, all right, because now we have the recombinant DNA concentrates that takes away the use of human-derived products, all right. But that used to be an option. For hemophilia A, which is your factor 8 deficiency, hemophilia B, which is your factor 9 deficiency. And again, definitely you'll see that using recombinant DNA. Advantages, it's in a vial, patients can reconstitute it and give themselves injections at home, all right? So it removes all of the having to come to the hospital for transfusions or injections, all right? And then they're also not exposed to infectious diseases. I took this chart from your textbook as well. It just kind of describes what would be the best therapy for each factor deficiency or condition, right? And then here would be your best therapy option. All right, so albumin and plasma protein fraction, these are commercially prepared from a large amount of plasma. Albumin is fractionated and then heat treated to kill any type of virus that might be a potential risk. They will use this if you guys ever come to the hospital and you present dehydrated or anything like that. They might give you what we call plasma expanders. Albumin is one of them. Saline is another one. Ringer's lactate that we're going to talk about is another option as well. So they're just kind of volume expanders, if you will. Immune serum globulins, this would be like IV IgG. So if they're doing that some with multiple myeloma patients, and that's just, they're doing that in order to build the immune system. And you can give specific immunoglobulins, like the one I mentioned is the IgG. Maybe they give that following an exposure to a disease, maybe given children following meningitis or some immunocompromised patients. I will say, if your patient is given IV IgG, this causes a huge risk or a huge problem for blood bank. Anybody want to guess why? It's IgG. And what do our antibodies, our unexpected allo antibodies that we try to detect, what are they most often classified as? IgG. So oftentimes, if your patient has received this, it's going to look like they have a warm auto. Okay?
Would you do an antibody screening before giving that?
Yep, so you're going to pick this up in your antibody screen. All of your cells are going to be positive. You're going to do a panel. All of your cells are going to be positive. Your DAT could be positive.
I meant for the patient that's given this intravenously.
You probably, if you're working with your clinicians, you want to establish a phenotype on them. So when this happens, you can give phenotypically matched, least incompatible units. There's growth factors. Growth factors can be used on the blood bank setting. Let's say if you're trying to harvest stem cells for a stem cell transplant, you could give your patient some growth factors. Erythropoietin, the granulite colony stimulating factor, or the GM, granulocyte monocyte colony stimulating factor. So blood bank will use those. That's more on the donor side and the stem cell harvesting side. And we talked about this before. If patient has severe anemia, giving them a dose of erythropoietin to stimulate red cell production. And then, like I mentioned, your stem cell transplant patients, they would give them growth hormones as well. And then we have our beloved Rhogam. Rhogam is the Rh immune globulin, and it actually was derived from a human, and we'll talk about him when we start talking about Rhogam, who was sensitized to the D antigen. So he has anti-D in his plasma. So his plasma was used in the first development of Rhogam. So Rhogam is actually used as a prophylactic, all right? So it's given to females that are Rh negative and potentially have an Rh positive. So it's given at 28 weeks of pregnancy, or if there's any type of trauma that she experiences while she's pregnant. And then following delivery, if she does have an Rh positive, she will be given another dose of Rhogam within 72 hours after delivery, okay? And it's thought that each full dose, and you guys don't have to know this right now, but in a later lecture you will, each full dose is about 300 grams, and it will clear a 30 mil bleed, all right? So when we say bleed, some of fetal cells are now in mom's circulation, all right? So if baby is Rh positive, mom is Rh negative, mom is being exposed to the Rh positive cells. She's being sensitized, she could potentially build anti-D. What Rhogam will do is it will coat those Rh positive cells, prevent mom from being exposed, therefore she won't build anti-D, which will affect her future pregnancies, okay?
So 2 questions. On that bleed, would we be able to see that with glycolysis?
So there is a test that we do in blood bank. It is not quantitative, it is qualitative, and it is the fetal screen. And so you guys will actually get to do that. If your fetal screen is positive, and there's a disclaimer, fetal screens should only be performed on Rh negative females, okay? If she's Rh positive, even weak positive, then your result is gonna be positive, all right? Because we are detecting the presence of Rh positive cells among the majority population of Rh negative cells, okay? So if your fetal screen is positive, then yes, you will follow up with the Kleiheimer-Betke, which will quantitate the number of fetal cells in her circulation, and then there's a calculation to determine how many vials of Rhogam she needs.
And then I know that kale is the most immunogenic factor.
Yes. There is nothing
So
for Kel.
we couldn't
No.
like synthesize somebody like we did
No.
with-
That's why I said if you guys invent something for Kel, you're gonna be rich, all right? And this just explains it's given at 28 weeks of pregnancy to Rh negative women, because at 28 weeks we typically don't know the type, Rh positive or negative, of your baby. So it's better to give it than not give it. So all Rh negative females are given Rhogam at 28 weeks, or in the event she has some type of trauma, even if an amniocentesis is performed. Okay. So Sarah asked, since it only protects such a small bleed, why only the 2 doses? And that goes back to the Kleiheuer-Betke, Sarah. You have to do the Kleiheuer-Betke. If she has greater than 30 mil bleed, she has to have additional vials. She'll have to have extra, yeah. And we'll talk about that in our moms and babies section. That's one of my favorite things, you guys, moms and babies in blood bank. Get ready. There's another use of Rhogam too. I've seen this done too. If you have an Rh negative patient who is in a trauma situation, and maybe your inventory of Rh negative units is very low, and you transfuse them Rh positive donor cells, we could potentially then give them Rhogam, which would coat those Rh positive cells, preventing your recipient from being sensitized to the D antigen. That's another instance of use of Rhogam.
Would that only be if the blood banker messed up and gave them the wrong?
No, so actually, it is a known situation. So in trauma situations, if it's a female within the childbearing age, and we don't know her blood type, we will have to give Rh negative, O negative blood. If your patient is a male in a trauma situation and we have pathology approval, I'm going to blow your mind with this, we will give them Rh positive blood just to conserve our Rh negatives. Because for what's the worst that's going to happen to your male patient? He's going to build anti-D, right? We'll be able to detect it in future testing. He'll just have to have Rh negative transfusions for the rest of his life. For females, if she builds anti-D, it could cause fetal demise for future pregnancies. So females, we always protect against that in females. Males, pathology will approve to give them Rh positive, even though they're Rh negative. You guys will see that, I promise, it will happen. We did it quite frequently. Yeah. And that's just because, especially, you might see blood donor centers put out a big announcement, blood donors needed, Rh negative, inventory scarce. And that's one reason why we kind of hoard our Rh negative units. So if a male patient is bleeding out and he's using a lot of products, we're going to give him Rh positive instead of using all of our Rh negatives. It's going to happen, I promise. We'll do it.
And in that instance, would you use Rhogam?
So I do not know the statistics of how often they will do that. It can be used, it does not have to be, but there are instances where they could give him Rhogam to try to coat those Rh positive cells, should still allow him oxygen carrying capabilities. So the benefits of the transfusion should be there without sensitizing his immune system, without him building the anti-D. So. But notice that it's really not noted in this presentation, so it's not a commonly used practice. I'll say that. It can be done. You might have some attending physicians, if they're in the ER state and they transfuse this male with Rh positive blood and he is Rh negative, they might say, hey, I want some vials of Rhogam. So it's possible. So here's some more of those volume expanders I was talking about. We have our colloid substitutes, dextran and hydroethyl starch. If any of you guys ever gone to the ER dehydrated, they've probably given you some of these substances. Crystalloid substitutes such as normal saline and Ringer's lactate. I have a disclaimer with Ringer's lactate. You guys need to know this. When our blood products are being transfused into the patient, they are always diluted with normal saline, all right, 0.85 to 0.9% normal saline. Ringer's lactate should never be used when you're diluting your red cells or other products for transfusion. It causes rouleau, all right? It causes the cells to come together. It could affect your patient's transfusion, okay? Ringer's lactate should never be used. So you will have this, you'll have a nurse call you and she'll be asking, how do I transfuse this unit of blood? What do I need to run with it? What type of tubing set do I use? All right. You tell her she needs to use it. Never use anything when you're transfusing products other than normal saline. All right.
What would you use Ringer's lactate for if you can't use it for
They will use it for like burn patients, if you're severely dehydrated, volume expanders, maybe if you need, maybe if you've lost a lot of blood, then they might give you that too. So, but it should never be used in conjunction with transfusion of a product. Sarah, they use Ringer's lactate on the battlefield? Normal saline? Volume expanders. Okay, yeah. Do you know what kind typically? The dextran? Okay. That must be a brand of the HES, I bet. Yeah. Okay, there's another concentrate, and you guys remember this is also related to coag, antithrombin 3. Remember, taking it back to coag, antithrombin is necessary in order for heparin to work to prevent the or stop the coagulation cascade, right? It inactivates factor 10, right? And so it's fractionated from human plasma, giving to prevent thrombosis. Remember, we have some patients that are AT3 deficient. Remember, if they are AT3 deficient, they are not bleeding, they are clotting because antithrombin 3 is needed to stop the clotting process. All right, so these patients are clotting if they're anti-3 deficient. Usually what happens is the clotting system is initiated. Remember, we had one of our case studies where the patient, a young newly married female, and she had started taking oral contraceptives. So that stimulated the additional hormones, stimulated her coagulation system. She was AT3 deficient, so she couldn't stop clotting, right? And then she had some type of embolism, all right? And so that's, remember, that's what AT3 is, all right? So there's concentrates that can replace that AT3 deficiency. All right, and the next few slides are just review, okay? All of the expiration times that we have gone over and you guys need to know, all right? For red cells, remember it is dependent upon the anticoagulant or preservative added. So if you had 3-PDA added, that is 35 days. If you had CPD, CP2D, that is 21 days. And then if you add Adsol as a preservative to your red cells, that is 42-day expiration time. And red cells are always kept at refrigerated temperature, 1 to 6 degrees, okay? However, we can freeze our red cells -65 up to 10 years from date of collection. And this just reviews some of the types and uses of all the products. Some of the testing, we've already gone over this. We were going to go more in depth into all of the infectious disease testing, all right? Whether it be nucleic acid, DNA, RNA detection, and we'll go into the most current practices right now, all right? So that's in an upcoming lecture. Platelets. You guys make sure you understand that platelets are kept at room temperature, right? 20 to 24 degrees, okay? And platelets require constant agitation. And we talked about 2 different types of collection: random, or like single donor, right? That's the apheresis. versus platelets collected from the whole blood collection. Remember we mentioned how you have to cross-match granulocytes? Typically for platelets, we don't cross-match. Sometimes we don't even honor the ABO of the platelets. However, if your patient is refractory and is not, their platelet count is not increasing with each platelet transfusion, that could mean that they have a platelet antibody. If they have a platelet antibody, we can cross-match platelets, right? So we take patient plasma and mix it with the platelets. Okay, so if your patient has a platelet antibody, it will be circulating in their plasma. And then so we can do platelet cross matches. UAMS actually does that. All right, we do platelet antibody identification and platelet cross matches. And the HLA lab will do HLA testing on our donor platelets to find HLA match platelets. However, sometimes we will just order HLA match platelets because it's easier to order them from a donor center. And then all the plasma, remember fresh frozen plasma, keyword there is fresh, meaning that it is frozen within 8 hours from collection. PF24 is collected within 24 hours. PF24 lacks factors 5 and 8, the labile factors. And then we talked about cryo, and we talked about some concentrates and plasma expanders. All right. Anybody have any questions? I promise you on your board of certification, you will have storage temperatures and expiration times on that exam, all right? I know you guys are all feeling overwhelmed, but if you just think about what the product is, what it's stored at, and your most commonly expiration times, just talk yourself through it, all right? Rather than memorizing that chart, but I gave you the chart, so if you are memorizers, you have it. And then Sarah had a question. Platelet consumption disorder of a heparin-induced. They have to be given a different substance other than heparin after that happens. So if a patient has heparin-induced thrombocytopenia, I wonder if they might rather just get Coumadin or warfarin. Yeah. All right, you guys have a good weekend.
I know.